Well, I think we're going to get started. My name is Randall Wong. This is our regular webinar on treatment for floaters. I'm a retina specialist located in Fairfax, Virginia. Many of you have met my assistant, my right arm, Chrissy, and I thank her for organizing this, and I thank all of you for coming and joining tonight. What we're going to do tonight is really just talk about the anatomy of the vitrectomy instrument. And then after a couple slides about that, then we'll open up the platform for questions and answers. I'd like to limit this to about a half an hour. So I'm a retina specialist. I'm in Fairfax, Virginia, in the United States, about 20 minutes out of Washington, D.C. I have two principal websites where you can follow. One is vitrectomyforfloaters.com. The other is retinaeyedoctor.com. This webinar is for informational purposes only. This webinar does not offer medical advice, so nothing should be construed as medical advice. The information on this webinar is only offered for informational purposes. You should not act or rely on anything in this webinar or use it as a substitute for medical advice from a licensed professional. The content of this webinar may quickly become outdated, especially due to the nature of the topics covered, which are constantly evolving. The materials and information on this webinar are not guaranteed to be correct, complete, or timely. Nothing in this webinar and nothing you or I do creates a doctor-patient relationship between you and the webinar, between you and me, or between you and Randall Wong, MD, or retinaeyedoctor.com, or vitrectomyforfloaters.com. Even if you try to contact me through this posting of the webinar or conversations through the webinar, we're not creating a doctor-patient relationship. Although I'm a doctor, I am not your doctor until and unless there is a written agreement specifically providing for doctor-patient relationship. Okay, having said that, what I'd like to do in about 5 minutes is talk briefly about what a 3-port vitrectomy system is. And this is the standard FOV system or vitrectomy setup. And on the picture on the right, you can see that there are actually 3 ports or 3 entries into the eye. There is and this is what we call a 3-port system. Very, very similar to arthroscopy. So we have 1 port for the infusion, 1 port or hole in the eye for light, and a 3rd hole or port for the vitrector, or otherwise known as a cutter. Now, what we're going to talk about briefly tonight are the different sizes these instruments can exist. There's 20 gauge. The lower the number, the fatter or bigger the diameter, by the way. There's 25 gauge, which I use almost exclusively. And there's also 23 and 27 gauge. And the genesis of these systems was, could we make smaller holes in the eye so that we do not need to use stitches to close them? Or at least that's one way to look at why we have so many different systems. Let's look at this historically. The first vitrectomy system was 20 gauge. That was around the 1980s. So we've evolved to develop thinner systems, 25 gauge, 23, and 27. What I want to show you specifically are changes in the vitrector. Now, all the instruments that enter the eye are of the same diameter, meaning if we use a 25 gauge system, A, B, and C will all be of the same thickness or diameter. A is the light source. That's the sclerotomy that lets a light emitting probe into the eye. B is a tube that keeps the eye inflated, and C is the vitrector. And what I'm going to show you in just a second are different or varying types of vitrectors. To give you an idea of what we're doing is, forget about the background, but this slide just shows that in this person's right hand, this is how we hold the instrument, and that long straw actually goes into the eye. So that's how we use it in the operating room. And if you look at a magnified illustration of the tip, the 20 gauge, which is the farthest on the left, look how wide it is, and look how big the orifice is, which removes the vitreous. I'm a big proponent of the 25 gauge. That's the third from the left. There are other systems, 23 gauge and 27 gauge. And basically for the discussion tonight, all we really need to do is talk about, okay, what's the difference in thinner instruments? Are there advantages or disadvantages? And when you talk about thinner instruments, in an attempt to avoid sutures and to decrease operating time, because in my view, if you have a faster operating time, you decrease the chance of the possibility of having complications, right? The less you're operating, the less time there is to have a mistake. Now, the question is, what are we giving up, or what do we need to consider when we're going to these thinner, more narrow instruments? Well, instruments are thinner, so they're less rigid. Number two, the holes or the orifices or the port where it engages the vitreous, and those are the holes, they tend to get smaller. These thinner instruments do have a faster cut rate, but with these thinner tubes and the smaller cutting port, it's very hard to get the same amount of suction, okay? So I'm a big proponent of 25 gauge. Going from 20 gauge to 25 gauge, I think decreases the chance of engaging vitreous, which means there's less chance of you pulling or tugging on the vitreous, which could cause a tear in the retina. I'm not so sure. I'm not a big fan of 23 gauge or 27 gauge at this point for various reasons, but I think the big game changer was going from 20 to 25 gauge. Okay, that's my educational slideshow for tonight. We've got about 20 minutes. Having said that, let's open it up to questions. If you wouldn't mind, type in the questions in the chat box. Okay, slow down, guys. All right, so let's start off with Joanne. I'm very nearsighted. Is that more of a concern for any risk factors? Joanne, nearsightedness is associated with a higher increase in retinal detachment, but in general, there's really not a concern. I generally don't worry about the degree of nearsightedness that you have or that you are. Josh says, is there any advantage to being young? Number two, what keeps the retina attached naturally? Number three, when natural PVD happens, what happens to the back wall? Does it fill up with new vitreous or fluid? Is there any advantage to being young? Yes, you feel like you can live forever. As far as a vitrectomy is concerned, not so sure that it really matters. It's a little more difficult to induce a PVD, but other than that, there's really no advantage or disadvantage. What keeps the retina attached naturally? This is a tough question. There is a space underneath the retina, which is a potential space. So, and the eye naturally absorbs fluid in that space, so the retina is attached. If you get a tear in the retina, extra fluid can get underneath the retina, and that detaches the retina. When a natural PVD happens, what happens to the back wall? Don't know what you mean. When a natural PVD occurs, the vitreous pulls away from the surface of the retina. So the space in between the back half of the vitreous and the surface of the retina just gets filled with water. Let's go back to Josh. Hello, hope all is well, and just had quite a few questions, if that's okay. Is it possible to wear a contact in the other eye so I can see after surgery while being operated, as I'm legally blind in both eyes and would like to see some images? Hold on a sec, guys. And I would like to see some images after. I'm considering a cornea transplant and was wanting to know if FOV should be done before or after. What would be easier? I'm set on having FOV sometime soon, though. How long would surgery take if general anesthesia, such as Valium? Thanks. If you're already set for a corneal transplant, I would urge you to get the corneal transplant first. It doesn't really matter, but if the corneal transplant helps your vision enough so you don't worry about the floaters, that's kind of a 2-for-1. But as far as the operating is concerned, as long as I have a clear view through that corneal transplant, I can do a vitrectomy. Sarah says, is frill around the IOL or off in the periphery somewhere? Is it attached to the crystalline lens? Frill, in my opinion, as far as I can tell, is the border where I stopped cutting vitreous off to the side. Has nothing to do with vitreous attached to the normal lens, which is also known as the crystal lens. If frill around the IOL, will it go away when I have cataract surgery? Well, if you've got an IOL, you've already had cataract surgery. I think if what you mean is if you've got frill, hold on a second. What happens is when everyone puts in questions, what I'm reading shifts off my screen. So if frill is around the IOL, will it go away when I have cataract surgery? It may, but generally frill is off to the side, so I wouldn't be concerned about vitreous stuck to the back half of the lens. She then asked if I need a capsulotomy, will that bring forth new floaters? It can. It certainly can. Wondering how old you are and whether or not any of this is a real concern. Does retina regenerate at all if laser is used on retina? Not that I know of, so no. Steph says, I'm a 30-year-old woman who developed floaters 2 weeks after PRK. I've been examined by many ophthalmologists who say my eyes are healthy, I don't have any retinal tears, and my vitreous is firm. Am I at higher risk for complications if I get a PV-induced vitrectomy at my age? I believe my floaters are small and close to the retina because I have crystal worms, hazy amorphous clouds, and gray shadows that move back and forth with eye movements. Also, 2 doctors who performed YAG treatments weren't able to see my floaters. I'm not surprised. You're 30 years old. Most people in your age group, the doctors are unable to see them. It's not a surprise that the YAG wasn't an available option for you. Vitrectomy should certainly help you. In my opinion, I think inducing a PVD increases the chance of getting a tear, but maybe somewhere around 2 to 3%. I don't know that I've really ever believed that any patient can tell how close or far the floaters are from the surface of the retina based on characteristics. I think that has something to do with some of the guys that perform the YAG saying, I can't do this because it's too close to the retina. I'm not sure if that's valid. Tuan says, I'm 29 years old. Joanne says, I had cataract surgery in February. I had YAG laser treatment at the end of April. Mark says, under what circumstances would you not want to perform the surgery? I think that if the floaters are due to some disease in the eye, let's pick a retinal problem where you are bleeding, so the actual problem is vitreous hemorrhage giving you the floaters. If you had chronic uveitis, which is inflammation in the eye, which can give you floaters, and there's a couple other less common scenarios. I don't think I would do this, but it really depends on what the cause is. In most circumstances, as long as you understand the risks, we can proceed. And this is, individual by individual. Joanne says, Joanne, Jesus. So Joanne had cataract surgery in February, had YAG laser in April, and that's when she developed the floaters. Does this put me at more risk? No, I don't think so at all. Whatever's bothering you is definitely in the vitreous. If you had cataract surgery, if you haven't had a PVD, will induce one. Shouldn't be a big deal at all. John says, is it true that the eye will filter out solution for its own fluid? If so, why can't the body filter out the bad vitreous to the floaters? You have to understand the vitreous is a protein which is trapped in your eye, and that's where the floaters are. So even though, think of the vitreous as kind of like a seaweed bed. So the aqueous, which is the water, would be the seawater that kind of nurtures the seaweed bed. So the seaweed never gets filtered out. It's just going to stay here. And that's the vitreous. John wants to know, is questioning how smart the machine is. The machine is programmed to keep the eye at a constant pressure when we're doing the operation. Tuan says, I have a partial PVD in my left eye due to trauma. I'm 29. What do you think about the chance of cataract in my case? Are there weightlifting restrictions, FOV? I can't comment about anything that you said other than the fact that I don't think there are any weightlifting restrictions at all after FOV. I don't understand what a partial PVD is, although I've heard other people talk about it. I would say that if you've got evidence of a PVD, if the floaters are bothering you and you're okay with, weightlifting after surgery, consider having something done. Tim, what are your thoughts on multiple FOVs? I had a non-PVD induced vitrectomy around 5 years ago. First 3 months, vision was basically perfect, then a large floater appeared. It's not dark, so lucky it's better than I had before surgery. But as always, it would be nice to not have them. I'm 33, but no signs of cataract from what I can tell. It is quite possible to reoperate. And same risks, same possible benefits, but I on my own, you could be my own patient. I don't think you are, but this does happen. One of the reasons that I'm doing a PVD, inducing a PVD these days is exactly what you went through. Sarah says, do I need to perform a wash vitrectomy for debris left over in patients to remove Kenalog? No, I don't. Kenalog gets absorbed rather quickly. We would just do a vitrectomy and that would clean everything out, I think. Josh says, some doctors that do FOV now are doing so with air bubbles versus gas. Do you see a benefit to this rather than having nothing? Does air bubble help with pressure? Air bubble does nothing, but probably increases the chance of cataract. I have no idea why some patient, maybe they think there's less likely chance of having hypotony the next day. I'd rather use sutures versus putting gas in your eye. John says, post-surgery, will eye be goopy or nasty looking? It can be a little bloody if that falls under the heading of nasty, but otherwise it looks pretty normal. I hear some people getting after images and seeing their own veins. Does this go away? I can't comment. I don't know really who or what's saying after images and seeing their own veins is not a normal complaint that I hear, so I can't really comment. Nelson says, if a tear occurs during surgery and it's repaired, will that spot where the repair took place be noticeable to the patient's vision? Usually, absolutely not at all. Sarah says, will fluid go through the sutures into the eye like when I'm showering? No. Any set time off from physical training like weightlifting or boxing? Absolutely not. If you become a patient of mine, I would prefer that you continue your normal activities within 24 to 48 hours. Case by case, of course. Dario says, in many FOV videos, I noticed a good amount of debris left in the eye mixed with Kenalog at the end of the operation. Either if it's my videos, it's due to editing, so you don't have to watch everything. If it's someone else's video, how can I say? How's that a small vitreal degeneration can cause annoying floaters without any chance of improvement and the debris apparently left in the eye post FOV would instead be absorbed and eventually disappear? I'm not quite sure what you're concerned about, but it sounds as though in some of the videos you're watching, it sounds that at the end of the operation, there's still stuff floating around. It's our experience that almost everything is gone, whether it's blood, whether it's catalog, or the initial floaters. All I can, I'd take this opportunity to say that the goal of surgery is to significantly reduce what's bothering you. I can't possibly guarantee that every floater that you notice is going to be gone. I can't guard against frill, but the deal is to improve your vision without harming you. If no retinal tears are left post-FOV, why is the risk of detachment still present after weeks or months? Well, I can't. You can either get a tear afterwards, or there might be a small tear that we don't notice during the operation. Is there any other way a detachment can occur apart from undetected tears? No. Do you always have to cut through the conjunctiva to perform the operation? The conjunctiva is on the outside of the eye, so I have to get through the outside of the eye to get to the inside of the eye. So yes. John says, can I opt for 27 gauge vitrectomies? I've seen people get this, and there's little trauma after. I'm younger and don't mind the surgery being longer. I don't have, and I don't do 27 gauge right now. I'm not, there are a couple things that I'm not happy with. So if you want to get 27 gauge and your heart's set on that, then probably, give another doctor a call. Right now, we're not totally convinced that we need to put all our equipment into 27 gauge. Some critics of vitrectomy, Steph says, some critics of vitrectomy state that the vitreous humor plays a large role in protecting the retina from UV damage. It filters UV rays that would otherwise damage the cells of the retina. They say that the aqueous humor that replaces the saline gas after vitrectomy does not have the same protective quality. It is a risk of losing UV protection and incurring phototoxic oxidative damage via vitrectomy and loss of the natural vitreous. I don't know how to answer you because that's someone else that's coming up with this conjecture. Nothing ever has been proven. I think that the natural lens, what may become a cataract someday, gives you UV protection. I can't say in this webinar how people come to other conclusions. I'm not aware that having a vitrectomy long-term damages the retina. And I've been doing this for about 25 years. So I guess to answer your question is, if the critics are having issues, then I would ask the critics to substantiate what they're saying. I have no idea why they come to their conclusions. Are there restrictions for air travel after surgery? Generally, no, not at all. In fact, most patients come in and leave the next day. Most patients from out of town leave the next day. If retina does not regenerate and we have to laser a tear, why will I not go blind in that area that was lasered? Generally, the areas that cause the tear are not very sensitive. That means we're not aware of the vision that it allows us. Do you still use Kenalog? And if so, have you ever caused macular hole or folds resulting in wavy images? I still use Kenalog, not aware of any macular hole that we've caused during the operation, and I think I would remember that. I don't know how folds would create, but no, not from what we're doing with Kenalog. Tim says, you were not my doctor. And to the person who asked about weightlifting, after surgery, I waited a few months, but now I lift weights all the time. There's been no issues. Super. Thank you for chiming in. That's more convincing than just me saying it's okay to weightlift and box. Sarah says, quick question on the lasering. Doesn't that make burns on the retina? How does retina heal the burns and allow us to see? Well, again, you're not aware or cognizant of the area of the retina that we're treating. So there's actually no compromise to your vision. John says, I understand that you don't normally collect data for these floater vitrectomies. Do you plan on collecting data sometime? Would be very helpful. I understand it'd be very helpful. I don't have the staff or the time. Doing what I do right now uses most of my time. Most clinicians in private practice are unable to keep statistics. And it's a cost and time issue. There is no way I can pay someone to follow up after everybody I see, especially for the out-of-town patients. For my own patients, I see them, and that's not a big deal, but it's very hard and time-consuming to keep track of everybody outside of normal appointments, and I apologize for that. It's just one of the quirks of our system. Josh says, I realize the vitrectors never pull on the retina, but when inducing PVD, I had to pull, and that tissue is extremely sensitive, that of wet tissue paper. How does that not tear immediately? That's a really good question. Pulling on the vitreous normally does not tear the retina. The technique in which we try to induce a PVD is slightly different than just creating suction when we're doing a vitrectomy. And that is a very counterintuitive answer, but all I can say is the two processes are not necessarily the same. Inducing a PVD is slightly different. What we're trying to do is create a separation between the vitreous and the retina. Aberrant tears can happen while you're doing the vitrectomy or actually while you're doing the PVD. So we're just actually very wary. But I guess what I'm trying to say is you can actually most of the time successfully create a PVD without the worry of a tear. Nelson says, can you share with us some of the common complaints patients have experienced following surgery? Blurry vision, double vision, redness. Usually everything's limited to about 3, 5, 7 days. Josh says, thanks for your help. Thank you for following. Sarah says, some images appear shaky and unstable at times. Could this be vitreous pulling on the macula? I doubt it. I don't know why you may have these. It's possible. It's really hard for me to guess over the internet. John says, can you see the crystalline lens and frill while operating? Well, crystalline lens is the normal lens. That's another name for your natural lens. So I can always see that. The frill, which is residual vitreous, is usually easy to see, but I can't always see all of it. Steph says, is the anatomy of the eye generally different between males and females? No, not that I'm aware of. For example, are women's eyes generally smaller in size and have to be operated on with more caution because of the smaller area? No, I'm not aware that eyes are different in size between males and females. John says, last one. I am 23 and don't expect getting cataract for another 20 years. After FOV, can my expectation remain the same, or should I expect one sooner? I have no idea. Cataract formation in every individual varies, and in every individual that gets a vitrectomy varies. I'm just going to answer it this way. It's our experience that our patients don't get cataracts after vitrectomy. And I'm not trying to dodge the question. It's just cataract. We don't know what causes cataracts. And there's so many people that get cataracts at a young age without vitrectomy. So it's really hard to pinpoint. John wants to know disclosing my complication rate. I think if you read the website, I'm pretty clear as to what I feel the complication rates are. I'm not gonna get into discussion to substantiate. Complications are probably less than 1 chance in 10,000 of getting an infection that could blind you, and probably about 1 to 2% chance of getting a tear that could lead to a retinal detachment. Tim says, I'm sure you have been asked this in the past. Why are most doctors so dismissive of floater patients? It's probably the most frustrating parts. Even after surgery, my own surgeon basically said that since she could not see anything in my eye, that with the technology she's using, that I was just super observant. I can't speak for her. I've done a ton of vitrectomies on young patients. I know that it helps. It significantly reduces the floaters. I have some of my own theories that I'll share with you when I meet you in person. I have, incidentally, and you can check this with everybody, I do not try to see the floaters that you see, because I should be able to see all of your vitreous and you should not be able to see any of your vitreous. So trying to find exactly what floaters you see that are bothering you is, to me, a moot point, because I know as long as you state that the whatever you're seeing moves to and fro with eye movement, vitrectomy will be helpful. I'm going to have to wind up soon, guys. But Sarah, when pulling on the vitreous off the back of the retina, do you pull the same way for every person? I do. I have a technique which I think reduces the chance of getting the tears. So I'm very, very cognizant of doing the same way. How do the sutures dissolve over time? They absolutely just dissolve with the tears. They're made of a polymer which is biocompatible, and your tear fluid will basically dissolve them over time. Steph says, one eye doctor casually mentioned that I have thinning of the retina. Would this make me a high risk of retinal tear? It might make you at risk for a higher tear, but probably of lattice degeneration. And I personally don't think a vitrectomy in a patient with lattice degeneration changes your risks. Tim says, thank you for hosting time and time again. Hey, I appreciate your plaudits. Thank you for following. Josh says, would I ever use the hypersonic vitrector? I don't know. It's not available for commercial use. In theory, it sounds really cool, but I have no idea. Right now, it is just a pipe dream. How long should you, Twan says, how long should be off from work? I generally think that my patients are allowed to go back. My patients I've operated on, can go back to full activity within 24 to 48 hours. Josh says, I hear people are cleared to fly after the FOV with you, but some people sustain pressure issues after they deal with altitude problems. Will you advise waiting on flying after FOV now? No, flying has nothing to do with the pressure problems. Pressure problems may be related to some of the drops we use afterwards, but certainly not because they're getting into a plane. If I plan on visiting you in 2 years, will you still be doing this? I plan on it. Can't promise a thing. Joanne says, I learned a lot. Thanks. Hey, thank you for listening and following. Sarah says, has anyone coughed or sneezed while being operated on? How do you deal with this? Let's just say we're under complete control. Sneezing and coughing is common and not a huge problem. Steph says, wow, you're amazing. Thank you so much, Dr. Wong, for hosting this. It's been extremely helpful and informative. Hey, you know what, guys? Thank you so much for joining us. We're going to do this again in about another 2 months. If you want to return and ask questions, that's why we're doing this. If you need to contact us, here's Chrissy's email. She can help you with insurance information and recommendations for surgery and help you with getting surgery scheduled. Josh says, what's the future outlook for your webinars? I'm going to try to do them at least through 2018 every 2 months. Will I be training younger docs for the FOBs? You know, every retina specialist has this ability within them. And whether or not they choose it for floaters only is their own decision. I don't particularly think I have any different skills other than I'm brave enough to do webinars and post things on the internet. But I do have several close retina specialists that I work with often. Let's leave it at that. Okay, you guys, I'm going to sign off. Thank you so much for joining us. I'm Randy Wong. Follow me at retinaeyedoctor.com or vitrectomyforfloaters.com. I want to thank Chrissy again and again and again for organizing everything. She will be your liaison if you need to get in touch with us to come see us in Fairfax, Virginia. Yeah, thanks for the comments about Beautiful Family. That was a while ago. I think we're all getting older, certainly fatter. All right, you guys, have a great night. Thank you.